Welcome everyone to Developing a Compliant Coding Query, presented by Amy Davis, Director of Inpatient Coding and DRG Validation Services, and Angela Zimmerman, Supervisor of Inpatient Coding and DRG Validation Services at Yes HIM Consulting. For today's webinar, you're in mute mode. If you have any questions or concerns, please post them in the Q&A section. We will be monitoring the Q&A section throughout the webinar. The chat feature is disabled. This session is being recorded. We've sent an email this afternoon with a link to download the webinar slides. There will also be a link posted in the Q&A section. After the webinar, we will talk about how you can access the CEU Certificate of Completion. But first, a little bit more about our presenters. Amy Davis is the Director of Inpatient Coding and DRG Validation Services at Yes. She holds a Bachelor of Science degree in HIM from the Medical University of South Carolina in Charleston. She has in-depth knowledge of health information operations with an emphasis on coding and reimbursement, and significant experience with the implementation of quality improvement systems to comply with Joint Commission and regulatory agency standards. Amy has been a manager of coding and operations in an acute care setting and has assisted with implementation and training on the Cerner document imaging system and managing the recovery audit process. She has worked as an independent coding consultant, coding specialist, case mix manager, and DRG validation analyst. She has taught coding and medical terminology classes and participated in the clinical documentation improvement process. Amy is a registered health information administrator and a clinical documentation improvement practitioner. Angela Zimmerman is the Supervisor of Inpatient Coding and DRG Validation Services at Yes. She has over 25 years of inpatient coding experience and over 10 years of clinical documentation improvement experience. Ms. Zimmerman provides inpatient coding and auditing support, reviews CDI mismatches, conducts educational coding webinars, and assists with developing best practices for the inpatient coding and clinical documentation improvement team. She has experience in coding and auditing at trauma centers, teaching facilities, and children's hospitals. She has experiences utilizing 3M, 360, CAC, HSS, TrueCode, Encoder Plus, WinCoder, WebStrat, Abstractor Plus, Meditech, HBOC, AS400, SMS, Affinity, 3M Front End, AMPFM, and McKesson HPF. Without further ado, Amy, take it away.
Thank you, Rachel. Good afternoon, everyone. Welcome to our town hall meeting regarding developing a compliant coding query. This slide is just our company's disclaimer. Let's look at today's agenda, which will include query definition and guidelines, types of queries, compliant query checklist, and we will review some query examples. Let's review the definition of a compliant query and the guidelines. Coding queries are requests for additional information from a provider to clarify medical record documentation. A query serves as a communication tool or process used to clarify documentation in the health record, to enhance documentation integrity, and to ensure accurate diagnoses and procedure code assignment for an individual encounter in any healthcare setting. The query guidelines, they are numerous, but let's work through some of them today. Your query should be compliant with the guidelines of achieving a compliant query practice that were established by ACTIS, the Association of Clinical Documentation Integrity Specialists, and AHIMA, the American Health Information Management Association. Queries should be brief. Information should be as clear and concise as possible. Be specific. Make sure to try to avoid complex phrases. Querying is not the time to educate the physician about diagnoses, procedures, coding rules, or guidelines. Of course, make sure that you adhere to the official guidelines when you are developing your query for compliance. Queries should be easy to understand and clearly state the issue you are questioning. Provide relevant information to assist the provider in making a determination when answering that query. Quotations may be used to cite the source of the clinical information within the medical record. So make sure you say where it's located, because we want to avoid introducing any new information. So, you may see systolic dysfunction within the H&P, and you see congestive heart failure somewhere else, and you just want to make sure that that is the type of congestive heart failure that the patient is having. Queries can contain appropriate clinical indicators from the medical record. Also, multiple choice query options should include clinically relevant options. So the word other or similar terminology can serve as an answer option to allow the provider to customize their response. Continuing with the guidelines, possible answer options that can be used but not required include unknown, not clinically significant, integral to, unable to rule out, inherent to, or other similar wording. Unable to determine requires specific consideration to determine if it is needed as a multiple choice option. Angela will discuss multiple choice queries when she discusses the types of queries later in this presentation. Present only the documentation from the health record identifying why the clarification is required, and never include the impact on reimbursement, quality measures, or other reportable data. As mentioned on a previous slide, your query should be compliant with the guidelines for achieving a compliant query practice. The guidelines were produced through the joint effort of the Association of Clinical Documentation Integrity Specialists, ACTIS, and the American Health Information Management Association, AHIMA. The associations collaborated on the creation of this practice brief and approved its contents as such. It represents the recommended industry standard for provider queries. According to the ACTIS website, following this 2022 publication, the committee realized the need for clarification regarding denial trends and queries, so an addendum was added in October of 2023 regarding this topic. As you can see, we have more information at our website at yeshimconsulting.com. There is an article there that is "Do Your Queries Follow AHIMA Guidelines for Achieving Compliant Query Practice?" When to query. When there is clinical evidence to support a medical diagnosis, but the diagnosis is not stated in the medical record documentation. To resolve conflicting information between providers. Sometimes we look at our documentation and are there inconsistencies in that documentation? Is there unclear information within the health record? Is there ambiguity, or is the documentation incomplete? So these are instances when we can query. Also, to clarify the reason for the inpatient encounter. To seek clarification when a documented diagnosis is not clinically supported, or again, when there's conflicting documentation. Also, to confirm a diagnosis documented by an independent practitioner who does not meet the definition of a provider in the inpatient setting. For example, confirmation of a pathological finding. We also want to query when we're trying to establish a cause and effect relationship between medical conditions. It may be necessary to clarify the relationship between medical conditions such as complications or manifestations. For present on admission indicator assignment, we want to query to determine if a diagnosis should be ruled in or ruled out. To establish clinically supported acuity or specificity of a documented diagnosis to avoid reporting a default or unspecified code. As you know, insurers do not like unspecified codes, so we try to code to the highest specificity. Also, to establish the relevance of a history of condition to determine if it is active. We want to also query to clarify a diagnosis on an ancillary note that has been signed but not addressed by the provider. An example is a nutrition note states severe malnutrition, and it is signed by the provider, but the provider does not address the diagnosis within their documentation. We also query to clarify the objective of a procedure and to clarify the absence or presence of a complication. The bottom line is to make sure your query is necessary. We want to integrate any coding guidelines, not writing out the total guideline. Like I said, we want to be as clear and concise as possible, but to just make sure that we are in compliance and addressing those things in our query. Quote documentation from the medical record, be brief, no War and Peace novels, just be very brief, state relevant clinical information, and ask appropriate, sensible questions. If it makes sense to you, it will probably make sense to the doctor, but make sure it is sensible in order to get an appropriate response for that accurate diagnosis and or procedure code assignment. The fun part, when not to query. If the provider can't provide any additional information or clarification based on the documentation in the medical record, it's probably viewed as an unnecessary query. We know how physician feels about queries to begin with. So if we send an unneeded query, we're probably going to make them very unhappy. So let's try not to generate any unnecessary queries. If there is no additional documentation to suggest that a code of higher degree should be assigned, and also if the answer options within the query are not supported by documented clinical data. We don't want to get an incorrect response, and we don't want to generate any leading queries. Directing a provider to a specific diagnosis or procedure, as we know, is leading. And leading queries don't ask questions, they steer or suggest a specific answer. and they tend to influence the provider's clinical judgment. So ask an appropriate question. For example, can you confirm or can you clarify? To avoid issues, perhaps your organization would like to develop a standardized format for queries. That way you can ensure consistency and compliance. By following these practices, medical coders, CDI specialists, providers, and other healthcare professionals can expect a more streamlined, organized clarification process. And when the query process is more efficient, all parties involved stand to benefit. I will now hand the presentation over to Angela to review types of queries, a compliant query checklist that we developed internally, and some query examples.
Thank you, Amy. That was a lot of great information. So let's take that and now let's talk about the different types of queries. Our first type of query is an open-ended query. This allows providers to add free text query responses which may or may not align with the documentation needed to support code assignment. This type of query is probably the least type of query that is used, and it is best used when you have limited answers. So an example of an open-ended query could be that a patient, their labs are showing that their sodium is low. The physician has documented that they're monitoring that sodium and replacing electrolytes. The coder could submit an open-ended query and ask, based on the clinical indicators, can you clarify the condition or diagnosis that's being treated or monitored? And then hopefully your physician will answer that as hyponatremia. Our next type of query is a multiple choice query. This should include clinically relevant options as supported by clinical indicators in the medical record. There's no mandatory or minimum number of choices necessary to constitute a compliant query. And providing a new diagnosis as an option in a multiple choice list that is supported and substantiated by the referenced clinical indicators from the medical record, that is not introducing new information. So an example for that could be that a patient presents with altered mental status and your physician has documented encephalopathy. The coder could then submit a multiple choice query and ask if the diagnosis of encephalopathy can be further specified. And then you would list out different types of encephalopathy as your multiple choice options. And I always tell our coders to include the diagnosis that is documented in the medical record. So in that case, encephalopathy unspecified should be one of your multiple choice options. You would also want to include other. That gives the physician an opportunity to write in their own type of encephalopathy if they don't agree with the options that the coder has listed. And then if unable to determine. A tip I tell our coders is to use your encoder or your code book. When you go and look up encephalopathy, it lists out multiple types of encephalopathy. And of course, you can then use that to build your multiple choice options. And keeping in mind that they must be supported by the clinical indicators that are documented in the medical record. Our next type of query is a yes/no query. This should be used to clarify documented diagnoses, and that's our key term here. It's a documented diagnosis that further needs specification. It may not be used in circumstances where only clinical indicators of a condition are present and condition is not documented in the medical record. So thinking back to my low sodium example, the coder would not be able to submit a yes/no query and ask, can you clarify if the patient is being treated for hyponatremia? Because in my example, hyponatremia was never documented in the medical record. Yes/no queries are used to determine POA status, substantiating a diagnosis that is already present in the medical record with interpretation by a provider. So if your facility doesn't have query templates, say for pathology, the coder could submit a query to confirm the diagnoses that are on that pathology report, or maybe there's a diagnosis in your pathology report, or an echo, or other diagnostic reports that the coder wants to query about. Yes/no queries can be used to establish or negate a cause and effect relationship between documented conditions, such as manifestation, etiology, complication, and conditions and diagnostic findings. So an example could be a patient has a UTI and there's documentation that there's a chronic Foley. The coder could submit a query to get that cause and effect relationship between the UTI and the chronic Foley clarified. And then also resolving conflicting documentation from multiple providers. For example, your attending is stating the patient has sepsis, but your infectious disease consultant is stating bacteremia. So you would want to get that final diagnosis of sepsis clarified. One tip I tell our coders is to not submit a yes/no query that has two questions that could potentially lead to two different answers. So for example, if the coder wants to clarify if the patient is septic and if it was present on admission, that's two questions that could end up being answered two different ways. Yes, the patient is septic, but no, it wasn't present on admission. So be careful not to ask two questions on a yes/no query. That your multiple choice query is probably a better option for that. Next, we're going to look at a compliant query checklist. Like Amy mentioned, this is a checklist that we came up with to help our coders when they are writing queries. We also use it because we periodically do query reviews on our coders. So looking at the questions, the first one is the query necessary? You may work at a facility where they have an internal guideline stating that coders can only submit queries if it changes the DRG or impacts your SOI or ROM. And maybe you've submitted the query and the discharge summary is now there, or there's been an addendum to a dictated report, and that information now answers the question that you were asking about. Is the query for the appropriate principal diagnosis, or PCS? So an example of that is maybe the coder is wanting to submit a query about sepsis, but there's documentation stating that the patient is post-op, or again, maybe the patient has a UTI and documentation that they came in with a chronic Foley. And really what the query should be for is clarifying if this is post-op sepsis, or establishing that cause and effect between the UTI and the chronic Foley, because there are sequencing guidelines that dictate how that should be coded. And then PCS, again, maybe you have a coder who has submitted a query to clarify debridement, but really what your procedure is an incision and drainage. Are relevant risk factors documented? Are clinical indicators documented? Are you introducing a new condition or diagnosis? Again, your facility may have an internal guideline where they don't want coders to submit queries that introduce a new diagnosis. They may view that is a CDI function and not a coding. Did you list out the treatments or interventions? Does the query question make sense? And are the query responses appropriate and supported by the clinical indicators provided? Again, read the question out loud to yourself and the query responses, because if it doesn't make sense to you, it's not going to make sense to the physician, which is probably going to lead to a unanswered query or an unable to determine query answer. Is my grammar and punctuation and spelling correct? Again, queries become part of the permanent medical record, so we don't want to have any kind of spelling errors or punctuation errors. If you do have query templates, I know that we have suggested to our coders to use Microsoft Word and write your query in that. That way, if there are spelling errors or punctuation, you can correct that before then copying and pasting that into your query template. Keep in mind font color. Your facility may have a guideline that states that you cannot use red font. That might be considered leading the physician to notice certain things and not others in your query. Are you allowed to bold or underline? And if you are, make sure you bold and underline all your clinical indicators, not some, because again, that could be looked at as you're leading the physician to notice certain things in the query and not others. I know that coders like to copy and paste from the dictated reports. Again, those dictated reports, they might be done in different fonts, different font sizes. So by copying and pasting into Microsoft Word, then you can correct that, make sure it looks all uniform, and again, not considered leading then. This is another tool that we have provided to our coders. It's the three-legged stool, and this includes all the relevant criteria that is needed to when you are writing your queries. So the first section, there's the clinical indicators. That includes your signs and symptoms. Again, I tell my coders, you can include signs and symptoms that support my diagnosis that I'm asking about and not support. I like to have all that information available so the physician can look at it and then make an informed decision based on what I'm asking about. Make sure you include your clinical findings, what diagnostic tests were done, and make sure it's provider documentation from that medical record. Risk factors, that include your comorbid conditions, past medical history, and chronic illnesses. Is the patient immunosuppressed or immunocompromised? Maybe you want to include long-term medications, antibiotics, or anticoagulants. Those things might be relevant to the question that you're asking about. What is the patient's age, activity level, their diet, nutrition? Again, that might be something that is relevant to your query question. Substance abuse, drug, alcohol, tobacco, again, that may be something also that's relevant that you want to include. And then finally, treatments and intervention, that includes your medications that were given, what procedures were done, what did my consultant say, and any change in level of care. So this is a really great tool to have for you and your coders. Now we're going to take a look at some actual query examples. So here's our first query example. Just by looking at it, it's a little overwhelming. That is a lot of information that we are asking our physician to read. And, Amy explained earlier in the query guidelines, we want it to be brief, to the point, only relevant information. And like I said, this is a lot of information, but we'll go through it and kind of pick out some things that are probably relevant to what we are asking about. So we can see that the patient has a history of COPD. They're on home oxygen at 2 to 3 liters. They have systolic heart failure, pulmonary hypertension, obstructive sleep apnea. And then there's mention of some chronic illnesses, the diabetes, the GERD, the gout. Not sure that that's really relevant to what we're going to ask about. There's mention of signs and symptoms that include the short breath, the cough times 3 days, the respiratory rate of 20, O2 sats at 96% liters of oxygen, and they have wheezes, some mild DSATs with coughing spells. The patient doesn't have a fever, and she's currently stable on 3.5 liters of oxygen. Her presentation is consistent with COPD exacerbation, likely mild heart failure exacerbation with pulmonary edema, and an elevated BNP. And then some information from a progress note, acute on chronic COPD. Here we listed out the treatment. That includes the nebulizers, IV Solumedrol, prednisone, Symbicort, Advair. And then for the obstructive sleep apnea, we have acute on chronic hypoxia, and they're going to continue nightly BiPAP. And then finally, our query question is, please respond with which of these is most appropriate in regards to the diagnosis. And our multiple choice options include chronic hypoxic respiratory failure, other explanation of clinical findings, or unable to determine. So now let's take a look and see how we revise this query. Again, this is much easier to read. It's to the point, it's clear, it's relevant. So we start off simply by stating that the patient was admitted with COPD exacerbation and systolic heart failure. We've listed out our clinical indicators of COPD on home oxygen at 2 to 3 liters. She has obstructive sleep apnea and is on nightly BiPAP. This time we included the APGs. We know those lab values are important when a physician is determining if a patient has respiratory failure or not. We documented the elevated bicarbonate, and then the treatment includes the oxygen at 3.5 liters, the duonebs, and the IV Solumedrol. And then our query question is based on your medical judgment. Can you further clarify the diagnosis related to these findings, such as acute on chronic respiratory failure, COPD exacerbation only, another condition, or none of the above? So much better multiple choice options. It's not a leading query because we've listed out multiple options and not just one like they did on the previous query. We also included the diagnosis that was documented in the medical record, that COPD exacerbation. We have other condition that gives the physician an opportunity to write in a diagnosis if it doesn't agree with what is listed there. And then, of course, the none of the above. So much better revised query there. This is another query example that is for a UTI. So looking at the query, it says per H&P, patient coming from facility, state patient had 101 fever this morning, patient taking meds for a UTI. Risk factors include COVID, dehydration, hypertension, and anemia. And the treatments are fluids, Paxlovid, and home meds. Our query question, please clarify the UTI. And then our query option choices there. The patient had completed the med for the UTI before coming to the facility. The patient's UTI was still being treated during her admission, or other unable to determine. So we are going to use our compliant query checklist to review this query. So our first question, is this query necessary? Based on the information that's in the query, I would say no. I'm not sure that this chart can support UTI as a secondary diagnosis. Did the coder list out risk factors, clinical indicators, and treatment? They do mention the 101 fever, but we can also see that the patient has COVID and is currently being treated for that with Paxlovid. So that fever very well could be related to the COVID. They do not mention any kind of urinary symptoms. Of course, we don't know where the patient is in their treatment for their UTI. Maybe they're on their last day of the treatment. Maybe it was recently diagnosed. We don't know if a urinalysis was done. So those are all things that probably need to be addressed with the coder and looked for in the chart. And again, for the treatment, they do mention that the patient's taking meds for the UTI, but the coder does not mention what exactly that medication is. If it's not listed in the home meds, or did the coder look at the medication summary that was, for the medications that were given during this admission? If there was no meds given for the UTI, then this chart probably doesn't support having UTI coded as a secondary diagnosis. And then query question to the physician, does it make sense? And query answers, are they appropriate? And can this query be written in a different way? So After reviewing this, chart again, I think we can all agree that either this query is not necessary, but if it is, then yes, we can all agree that it probably should be rewritten. Moving on, here we have another example of a query, and this time it's for respiratory failure. Per the H&P, acute respiratory failure with hypoxia, continue oxygen supplementation, hemodialysis will likely alleviate. And then some information from two different progress notes. We have improved after initial hemodialysis session for removal of 3 liters, still requiring supplement oxygen. And then hypoxic respiratory failure because of pulmonary vascular congestion, has improved status post-dialysis, but still need to challenge a bit. And then our query question, please clarify the reason for the patient's respiratory distress. And our options here are acute respiratory failure with hypoxia because of pulmonary vascular congestion, end-stage renal disease treated with hemodialysis to remove fluid, and other. So again, using our compliant query checklist, is this query necessary? I'm going to say no, because this query is somewhat confusing as to what the purpose of this query is. Did the coder list out risk factors, clinical indicators, and treatment? I said yes. They do mention that the patient is hypoxic, that they're getting treated with supplemental oxygen. They mention the hemodialysis, but there's probably some more clinical indicators that are present in the chart that should probably be included. Were there ABGs done? What's the patient's respiratory rate? Was there any other signs and symptoms, wheezing, or, things like that could be added to this query. The coder does mention the end-stage renal disease there in the answer, but doesn't include that as a clinical indicator. So that may be an clinical indicator that we want to add to that query also. Does the query question to the physician, does it make sense? And are the query answers, are they appropriate? And can the query be written in a different way? Again, like I said, this query is somewhat confusing. The question includes the diagnosis of respiratory stress. So I'm not really sure where that term comes from. Is that something that the physician documented? Maybe that should have been included in the clinical indicator. But it seems like we have acute respiratory failure as a confirmed diagnosis, as it's documented in the H&P, and then further into a later progress note. And that progress note then also specifies what is causing the acute respiratory failure. So I think we can all agree that if after review of that chart, again, this query, if it is needed, can be rewritten. So now we're going to move on and we're going to look at some actual medical record documentation, and we will use our compliant query checklist now to help us construct a query. So here I have my discharge summary, and I've already highlighted for you the things that are pertinent in this discharge summary. So we have a diagnosis of hyponatremia. It mentions that they gave the patient sodium and monitored closely with repeated labs. The patient's acute workup in the emergency room showed hyponatremia with a sodium of 124 and her baseline being around 129. And then our final diagnosis there is hyponatremia. And again, reiterates that the patient was given sodium and their labs were monitored throughout the admission. Here we have a consultant who states that on arrival, her sodium was 124 and she was started on IV maintenance fluids. On 12/27, her sodium increased to 127, but then decreased to 122. The patient reports chronic nausea and IBS with diarrhea up to 6 times daily. She reports she has minimal daily intake of food due to constant nausea. And currently her sodium is 122. Her albumin is 2.6. And our consultants Diagnoses are euvolemic hyponatremia, SIADH versus low solute intake, and then also pseudohyponatremia in the setting of hypoalbuminemia. And then further it states that the urine studies are consistent with SIADH. And also mentions that they gave tolvaptan and replaced electrolytes. So now we're going to use our compliant query checklist to help us build our query. So is a query necessary? Yes, we have conflicting documentation. And as coders, it's our job to bring that to the attending physicians to notify them of that conflicting documentation between the hyponatremia and SIADH, because we all know that those conditions go to two different DRGs. And we also have pseudohyponatremia that's documented by that consultant. And then we all know that based on that coding clinic from first quarter 2020, pseudohyponatremia is a lab finding, and that should be coded to the underlying condition. Our risk factors, that includes chronic nausea, IBS with diarrhea up to 6 times daily, and minimal daily intake of food due to constant nausea. Our clinical indicators, there's acute workup in the ED, showed hyponatremia with a sodium of 124 and her baseline being around 129. On 12/27, her sodium increased to 127 and then decreased to 122. Her albumin is 2.6. Euvolemic hyponatremia, SIADH versus low solute intake, and pseudohyponatremia in the setting of hypoalbuminemia, and urine studies are consistent with SIADH. The treatment, the patient was given IV maintenance fluids. They received tolvaptan, 15 milligrams one time a day, sodium chloride tablets 1 gram twice daily, and they replaced electrolytes. What is the query question? Due to conflicting documentation, can you clarify the diagnosis that's being treated? And then we would list out for our multiple choice options, hyponatremia, SIADH, pseudohyponatremia due to hypoalbuminemia, other, and unable to determine. So that is how we use our compliant query checklist to help us build a compliant query. These are the references that we used during this presentation for you to have and go review if you would like.